We, or people we know and love, have some emotional problems. Years ago, one of the famous Menninger brothers in Kansas used the illustration of a skating rink to talk about how we work with those. We may be going round and round, skating in a circle, and could lose our balance and fall down. Others come and help us up again. We catch our breath, go to the side, rest a little bit, and then get back on our skates and go again. We all know of Oaklawn Psychiatric Center, which serves thousands of people in Goshen, Elkhart, and Mishawaka. Oaklawn has grown both in space and in mission, and we'll learn of some of the newer programs this morning. Her father, Harold, and mother are also now of blessed memory, but we knew of them. I recall being with Harold on some MDS work years ago when I was more fit. She's president and CEO with oversight of all the programs, the budget, and of course is responsible for satisfying many accrediting agencies. She's been chair of the board at her home congregation, 8th Street Mennonite Church. Her expertise is valued by a dozen other agencies. She's on a lot of boards, from Greencroft to the Elkhart Board of Health. Lori, we look forward to hearing more about Oaklawn, and we'll hear if you keep this about 2 fingers away from your lips.
John warned me about that, yes. We'll see how this goes. And if not, let me know because I'll adjust. Okay, thank you. I will say Robert and Dorothy were my SST leaders in Honduras long, long ago. We had a great time. We gave Robert a few anxious moments, but it was good. It was good. And a special shout out then to Carl and George and Jenny and Marty, who are at least the 4 that I know that have worked at Oaklawn. So I'm going to start by talking a little bit about Oaklawn today. So Oaklawn is the community mental health center for both Elkhart and St. Joseph counties now. We have about 909 employees, 4 campuses. Elkhart was our first campus, and we opened our doors way back in 1962. And then Goshen, when we built the hospital. And then we took over in South Bend in 2010. And then a campus in Mishawaka with a large youth residential program in 2013. So I drive around a lot. We provide a variety of services, outpatient, of course, inpatient, both at, well, outpatient is on 3 of the 4 campuses. Inpatient is here in Goshen. We do a lot of community-based services. And we provide a lot of housing services, and I'll probably talk about that a little bit at the end. At any given time, we have about 450 people either living in one of our group homes or an apartment building that we work in, and we also have vouchers to subsidize housing for people to live in the community. So we believe and understand that safe and stable housing is really important in order to even start treatment, let alone maintain it. And so that's an important part of what we do too. We now have 2 crisis centers, and we have mobile response teams, and that's relatively new, and I'll be talking about that. And all services are provided regardless of someone's ability to pay, which is a real blessing that we can do that. You know, there are some for-profits and whatever where a wallet biopsy is kind of part of the admission process, and we don't have to worry about that. We can serve anyone regardless. So I'm going to go back into the beginning. And some of this will sound very familiar to many of you. So back in World War II, there were conscientious objectors, young men for reasons of conscience who did not want to provide military service, sought this status, and they were awarded that by the government. The the range of service assignments varied. Some of these young men helped to build dams, some of them worked in national parks, but some of them were assigned to work in state mental hospitals, and that's a connection to Oaklawn. So this was back in the 40s, remember? And the way we treated the mentally ill back then, frankly, wasn't very good. I mean, doing the best they could, but we didn't understand much about these mental illnesses and way to treat them. So they learned a lot by working in these state hospitals. And they also, in the course of that, learned that these are children of God and they deserve to be treated better. And so they did their service, they did the best they could. So they came home at the end of that. And that led to a bunch of conversations about, couldn't we do something better than this? This isn't very good care. So in 1954, 43 MCC reps from these Midwest states, Ohio, Indiana, Michigan, and Illinois, gathered in Goshen to talk about mental health and what could we do that would be better. And they agreed that we need, the minutes show, a more Christian and professional care in mental health. Not just more Christian, but and professional, it's both. They wanted to do this really, really well. So, of course, time passed, lots of committee meetings, as we love to do. And finally, then in 1962, we opened our doors in Elkhart. We looked around a little bit. They considered Northwest Ohio. They looked in the Fort Wayne area, but they did agree in the end that Elkhart would be the best place. Bob Hartzler was our first administrator. He was also instrumental in the founding of Greencroft, for those of you who might know that. And Otto Clausen was our first medical director. So fast forward just a little bit. This is a picture of President Kennedy signing the Community Mental Health Center Act of 1963. And this was a really big deal because it was the first time that there was any kind of federal funding for behavioral health or substance use services. And the way it was written, it was left up to states, as we often do, to choose whether or not they wanted to take the funding and how they wanted to do it. So it became part of Oaklawn's discussion. We were about a decade old at this point, and we decided, yes, this seemed to be a good fit with what we wanted to do, and so we applied and then were awarded the opportunity to be the Community Mental Health Center for Elkhart County in 1973. So today we're one of 24 CMHCs that cover the whole state. And with that comes some funding. It's written into statute. It's a combination of federal, state, and county. I would say that in the grand scheme of things today, it's not a huge part of our budget, but it is huge in that it shapes who we can serve and our obligation to them. So the clinical obligation is that we are to serve as the safety net, if you will, for people who are profoundly ill, both adults and for kids. And we embrace that and say, those are our people. I should probably fill in some acronyms. So adults with serious mental illness or substance use disorders, and youth who are seriously emotionally disturbed. And then, because we have this funding, this is why we can provide services and the obligation to do it without, regardless of their ability to pay. So it's the variety. We serve some people with great insurance. It's less than 10% of what we do. We do a lot of Medicaid work. Close to 60% of our total budget is Medicaid. And then Medicare is a big funder. And then also folks with no payer at all, and then we just serve them on an ability to pay scale. All right, so we have this CMHC system, and you remember that I said that President Kennedy, the way the law was written, states could choose whether they wanted to participate and how. So when you allow that kind of choice, which is nice, every state is different. and I'm really aware of this as I do work and kind of get to work alongside partners from Mennonite Health Services from different states. So there's wide variations in service delivery. Some states choose to put services for folks with intellectual development disabilities right together with behavioral health. In Indiana, they're separate, and that creates some friction sometimes. Big variation in how they're paid and what's reimbursed. There have been times with my MHS partners, I just say, you get paid for that because, it doesn't happen here. And there was very little accountability for outcomes. So I would have to say it's been a good but imperfect system. So fast forward now to, I wrote it down, 2014. Congress passed the Excellence in Mental Health Act. And what that is a national attempt to standardize care, to set standards and say this is good mental health care, and this is how it should be done, and this is what should include. So it created this criteria for this new acronym that we now live with, CCBHC, which stands for Certified Community Behavioral Health Clinics, CCBHC. I would say that's an unfortunate acronym, but we're living with it. So it allowed for $25 million in the beginning for states, if they wanted to pursue this, to get planning grants. And these were 2-year pilots. And it was a way to test the ability, prove that this works, it's better, and it's got this expectations of tracking data and outcomes to prove that, yes, this is a good idea, with the idea then that there could be continued funding and supportable funding, and it could grow to all 50 states. So let me say a little bit about this. As a CCBHC, there's a list of services that you have to provide. And when we first thought about this and looked at it, we looked at the list and it was like, most of it was stuff we were already doing. We could just check those boxes, it was easy. But what's also different is that there are 2 things I would say, a real focus on evidence-based practices. And what that means is there are practices out there that have been researched that show that they work, and you have to use them to fidelity. And so we agree with that. It's been true all along. As the field continues to evolve and we learn more, we're interested also in these evidence-based practices. And with the CCBHC, they say this is how you need to work. And we said, okay. The other thing that has really pushed us, though, is there is much more emphasis on access to services when and where you need it. And that has filled a big hole, which I think is a good thing. It also includes, frankly, a much better and sustainable payment model. We have always gotten by in our world. Sometimes we've said that we feel like the redheaded stepchildren. Sorry if there's any redheads here, in the healthcare world. And so to have a sustainable model that is built on it's called a prospective payment system, where it actually looks at what it costs to run a business, and then they back into it and set the rates that way. It's the same model that federally qualified healthcare centers like Maple City Healthcare Center, those kinds of places, they get to use, and this is a real positive change. And then, as I've mentioned before, very high expectations on tracking what you're doing, and is it working, and are people getting better? And are you able to reduce reliance on unnecessary higher level services? So I will say this shows a complete model that we're working towards, but it's, I would say in our world, we have had for many, many years an incomplete model, and not just Oaklawn, it's the whole behavioral health world. We've had outpatient, little prevention, outpatient, and we've had hospitalization, and there has not been anything in the middle. You know, in our physical health care world, we have urgent care centers. And everybody here knows what an urgent care center is, right? For your physical health care, and you know when to use it. It's that time when you feel bad enough that you don't want to wait to call your doctor and have to get an appointment and go in a day or two. You also know I don't need an emergency room, and I don't need to go to the hospital. And so we have urgent care centers. In our behavioral health world, there has been no equivalent of this urgent care situation. And that's what we have been filling now for the last couple of years. So, our journey at Oaklawn for the last, since 2021, we applied for one of those pilot sites and got a grant, and we're very excited about that. So that had started in 21. These are 2 years grant. And one of the first things we did in December of 2021, we built and then deployed mobile crisis teams. So staffed with a therapist and a case manager and backed up with a nurse and a peer recovery specialist, and I'll explain in a minute what that is. They are equipped and able to jump into a car and go to a situation. Sometimes they go with police. Sometimes we go without police because we've assessed that actually having a police presence there can make it worse. Person in a uniform. And then sometimes we have a protocol we work out with law enforcement. It's like, nope, Oaklawn should not come now. So we have protocols that we're developing about that, but we are equipped to go out into the community to sort it out, de-escalate, and work at that. It's a really great thing. Let me explain what a peer recovery specialist, because this is, in my long time at Oaklawn, a relatively new thing for us. So peer recovery specialists are people that we employ who bring what we call lived experience. They have their own behavioral health or substance use recovery experience, and that is worth gold. We find that when you can partner a peer with, say, a professional who's got credentials and school learning, but you put the two of them together working with someone, the peer is the one who can say, you can do this because I did this. I know what you're going through. I know how hard it is. Stick with me, I'll stick with you. They can just bring wisdom and empathy in a way that doesn't come with book learning. And so we employ at this point, probably over 40 peer support specialists working in a variety of our programs, and they are really effective and cool, for lack of a better word. So in then May 22, we launched open access. So up until then, our outpatient practice had been like everybody's. You need an outpatient appointment, you call, we'd ask a lot of questions, and you tell your story, and then we would say, we check the schedule, and we'd say, okay, check your schedule, our schedule, so come in 3 weeks, and we'll see you, because that's how it goes. And no surprise, 3 weeks later, when it's time for your appointment, our show rate was about 50%. A very inefficient model. With open access now, what we say is when you call, we say, come in today. And then if they would happen to say, well, but I can't today, then we'll say, then come in tomorrow. Because every day for 6 hours, we have master's prepared therapists who have created flexibility in their schedules to be ready for whoever walks in the door. And we'll do a risk assessment, a full assessment. By the end of it, and it takes an hour and a half, there'll be a diagnosis, a preliminary diagnosis, a treatment plan, an appointment. You'll be ready to go. So we piloted, let me say this was one of the most interesting things I've done professionally. This was a huge change for us. Our therapists were used to predictable schedules and some say-so, and they knew what was going to happen every day, and we were asking them to work flexibly like never before. Also, we were organized by a kind of adult services and services for youth. So some people only saw adults, and some only saw addictions, and some saw kids. And now we're asking them to see whoever walked in the door. They were all trained for it. They got all that in grad school, but so that rocked the boat in a big way. And there are a few people, frankly, who decided it was time to retire. But we've hired a lot of people since then who know what this is and like the flexibility and the variety, and others who have seen, oh, this really works. You know, Ken Yoder, some of you may know him, has been at Oaklawn even longer than me, and he loves it. You know, just I think the variety of it. So, the first week of open access. Now, you know, there was some pent-up demand. We saw 55% more people, and we thought our heads were going to explode. It was like, oh my gosh. We got through that and we managed it. And today, a couple years into it now, this is our way of operating. We are seeing, compared to before, about 33% more people. And so it's very effective that way. And people can get in to be seen when they want to. And that's a wonderful thing. I have heard way too many times in my career, but you can't get into Oaklawn. And I would say, well, yeah, you can. You know, you just have to wait a little. But you can get into Oaklawn now, and that's a terrific change. Then in September, we launched our Elkhart County Mobile Crisis Team. So it's the same as the St. Joe County team, able to respond as needed. And then the state decided they also wanted to make a application to the federal government to be one of the, I think they chose 10 this time, 10 more demonstration grant sites for states. And they were going to pick just 8 of the 24 community mental health centers to be part of this pilot. And so we went through a rigorous process of having to explain everything. And in the end, they chose 8. And there was a lovely day in December of 2023 where we got the phone call that Oaklawn was chosen to be part of this pilot. And that was honestly one of my happiest days at Oaklawn. So then last year, we opened the first crisis center in St. Joe County. And this is a low barrier, 24/7 program where anyone, any adult in crisis, as they define it, and sometimes those crises are big and sometimes they're smaller, can walk in and be seen and can stay as long as it takes. And so I'm going to tell you about the very first person. It gives you some sense of how flexible we are. So when we opened at 8 o'clock on that very first morning, the police were there with a gentleman that actually we knew. I mean, because some of these people, these are chronic mental illnesses, and we know them well. He had been up all night long. The police had been involved. They didn't want to take him to jail. The ER didn't want to see him, and so they knew this was going to open. So they just parked in front of our door, and so he came in. He was known to us, so we had some clinical information on him. One of the first things he did was take a nap, and we were equipped for him to do that, and so he slept for a couple hours, which was very needed at that point. Then he woke up, and then we talked and found out what was going on now, and we fed him some food, made a plan, got him back. He was off his meds, and we knew who his provider had been. We were able to call up to one of our physicians, get meds back in him, get him going again. And that's just such a nice example of how flexible we can be. And it works. And he still drops in a crisis every once in a while, and that's okay, because we want to keep him out of jail, out of the hospitals, out of the ERs, and we're equipped to do that. In June, we found out that Indiana was chosen to be one of the 10 states. So we knew that, okay, this thing is really going to happen. We can become a CCBHC. Another happy day. We opened the Elkhart County Crisis Center just last October. Same model, renovated some space on our Goshen campus, and that's been operating ever since, 24/7. And then we were officially designated as a CCBHC in December. So let me say just a few words about open access, which I described for you. We're seeing now about 9,000 walk-ins annually, and I showed you how it's those first 12 months were very high volume, and now we're still about 33% more. In about 76% of the time, we do for those people walking in, the whole assessment. About 16% of the time, we don't get through the whole assessment because determined that there's a better path here, but we always screen for risk. So sometimes we can determine pretty quickly that, oh, they need to go to the crisis center, and then that's a simple phone call, and the crisis center takes them. Sometimes we've known that, oh, they need to be inpatient, and then we help facilitate that. And so sometimes also we can say, okay, they don't have time to stay, and we'll say, okay, we'll give you a priority pass and you can come back. And then 4% of the time, then we can make connections with other referrals, community-based programs that we don't provide those services. So for crisis now, there's 3 parts to this. Someone to call, and we have a round-the-clock phone service, and we can do triage and direct them to a place. 80% of those calls can be handled on the phone and resolved that way with some kind of plan by the end of it. We have, as I described, someone to go. Those are our mobile crisis teams and our crisis centers. Our goal with law enforcement is, and the deal with them is if they bring somebody in, we will accept them every time, no questions asked. And the goal is to have the police in and out within 10 minutes so they can be back in their cars, back on their job, and not having to work with mentally ill patients who they aren't really trained to do. This is a busy chart, but I'm going to highlight a few things for you. So we're keeping, as I mentioned, we have to track data on everything. How's it going? And so we track really carefully the number of times that we go out, the number of times it is escalated beyond crisis center, like to inpatient or to an ER, and how many are resolved. So the blue is kind of our goal. And so you'll see that as we've opened up crisis centers and expanded service on the right-hand side, we're able to resolve more without having to escalate and can serve people kind of meeting our goal. So right now, we continue to work on open access, crisis services, getting not every team is at 24/7 yet, so we're expanding our capacity that way. Care coordination, and outcome monitoring. Is this working? All right, I've done a lot of talking. What questions do you have, and how can I respond? Yeah.
For that.
We have to.
I haven't heard it yet.
Since you're getting federal money, do you have to report to ISIS? Do you have to find out whether they're documented or undocumented?
No, we don't have to report. There's still some protections with HIPAA and around services. We've done a lot of training with staff on this, and they haven't dropped in unannounced, but we've done a lot of training with staff on that. So if they come in, they don't have any rights unless they've got a warrant. We've trained staff to say that and say, sit tight, we'll get an administrator. Because for staff, it's like, what am I going to do? And so we try to manage that saying, okay, let us know and we'll deal with it, and go at it that way. There's a lot of anxiety. We have some clients, we have a Spanish-speaking addictions group, and attendance has been down, and I think they're laying low. So we're trying to be as sensitive as we can and not doing anything more than we have to.
Could you comment, please, on your outreach to the Amish community and the various states that are taking advantage of that?
So I didn't check my dates. This is a long time program, and it's a great one. It started way back when Hal Lowen was president and Sam Bontrager was on the board. And he went to Hal and said, Hal, I've got a real heart for the Amish. I think I'd like to hire me part-time to do some bridge building. And so all these years later, we have 3 group homes. Rest Haven, which is for people who are Amish folk who would have been maybe, say, on our inpatient unit, but aren't ready to go home, and so they go to Rest Haven. We have Pleasant Haven, which is just across 15 there, and that's for men for probably more chronic conditions, and they stay there a long time. And Horizon of Hope, which is a group home for women. In every case, they are owned by, they sit on our land, so it's an interesting lease. But they built the houses, own the houses, and provide the 24/7 staff. We provide the psychiatrists and social workers and clinical work. And so it's been a really interesting and satisfying partnership for all these years. Also, if you drive past our campus, if you're headed north on 15, you'll notice that there's construction on our campus right now. As I mentioned, housing is a big deal for us. And so we partner with La Casa, and we get funding from the Indiana Housing and Community Development Association. And they build and own the houses, and we provide the services. And for this project, it's on our land, which helps make the project affordable for everybody. And we'll have, in the end, 7 group homes, 8 apartments in each one. 4 are 1-bedroom and 4 are 2-bedroom. And it'll be for folks who have been formerly homeless, who meet criteria then, or they don't have to meet clinical criteria, because you can be in our housing without being in treatment or being sober. That's part of the deal of having safe and stable housing first is most important. And one of those 7 houses, this one is first for us. We're also partnering in this case with Basher, and it's specifically for young adults 18 to 21 who are aging out of the foster care or residential system. No surprise, these young adults with no safety net under them end up being too often homeless or unemployed. And so this will provide housing and supportive services for that group, which is also cool.
Thank you for this enlightening presentation. Are there opportunities for the public to cross the threshold of Oaklawn? I know years ago in Elkhart, our church used the gymnasium for square dance, meals, and it gave us an affinity for what was happening at Oaklawn.
Good question. Yes, and so we have some volunteer opportunities that our foundation helps to organize and manage for us, as well as the Exchange Club meets there every Tuesday morning for breakfast, uses our kitchen services, and so people are welcome that way. Yes.
Just a note to the people on Zoom, if you wish to ask a question, put it in the chat, and John will keep monitoring that and let her know if you want to ask a question.
Carl.
Thank you, Lori, very excellent presentation. I had 31 good years at Oaklawn. You recall this early history, no doubt. We had what was called day treatment. And so we would admit patients to Elkhart General Hospital psych unit, and then from like 9 to 3, they would come to the Oaklawn campus in Elkhart for what's called day treatment. And that went on for quite some years. Also, when President Kennedy developed the CMHC program, wasn't Oaklawn featured in a brochure way back there as an example of what a mental health center could be like?
Yes, we were. I've got a copy in my office. Yeah, there's a lot of, we're 65, 66 years old now, whatever. And so we are, even of the 24 CMHCs, one of the longer functioning ones.
How are the 24 organizations in Indiana organized to exert their political power in both state and federal?
Great question, which is real important these days. So we do have an association, the Indiana Council of Community Mental Health Centers, and we do have spent more money on lobbyists in the last few years, which is so important. You know, in the previous, not most recent, the previous budget cycle under Holcomb, Governor Holcomb, actually mental health services got as good attention and buy-in as I've ever seen. It's different now, but the Braun administration so far is supportive of this CCBHC thing. They like the fact that it does seem to have some data. They like numbers. Seems to be some data and some results that say, okay, this can save money, this can be effective. So we're playing that card as hard as we can. We're also, we also, as an association, spend money for federal lobbyists because, as I mentioned, Medicaid is very important to this whole system. And so I am carrying a low-grade anxiety these days about what's going to happen to Medicaid. The two things in Indiana that did pass the budget that I think are problematic. One is work requirements. And with some exceptions that some of our clients will fit if they jump through enough hoops. But probably the very worst thing is they're now saying that to maintain Medicaid eligibility, there need to be quarterly redetermination of eligibility. And I've said this to my board and to every group I've been in, that I would posit that everyone in this room, if they had to quarterly schedule an appointment, gather up all your stuff, show up, have an appointment, would have trouble maintaining your health care. And they say, okay, I'm going to editorialize just a bit. They say this is about fraud and abuse. I don't think, you're not kidding anyone. This is about trying to keep people off of Medicaid or kick them off if they have it. So I'm worried about that. We will hire some more navigators to make it their job to keep track of our people, help them store stuff, documents, and try to keep their lives organized enough to maintain their Medicaid eligibility. But I worry about that.
Do you still have a school for inpatient children at Oaklawn?
We no longer have an inpatient unit for children. We did for a while. But what we have now is a large youth residential program in Mishawaka. So today we have 73 kids who are there, and these are kids who are referred to us from either probation or the Department of Children's Services. They can't live in the community for right now. They stay 3 to 6, 9 months. And we have a contract with School City Mishawaka, who provides the schooling on grounds for those youth. So they don't fall behind academically and can graduate and with their high school credits. And
In the early days of my association with Phil Haven, there was a connection with those other Mennonite hospitals. What has happened to that, and where are you with that mental health in Mennonite Church?
that happens primarily now through Mennonite Health Services. So the connection is voluntary, but it's been really helpful. Phil Haven, Prairie View, Penn Foundation, 7 of us, whatever there were. Now they've made changes. Phil Haven, of course, has merged with a big hospital system out there, and Brookline recently did the same thing. So it's changing over time, but that's been a valuable relationship and one I've appreciated. Yeah.
Are most of your patients on some kind of medication coming in for antipsychotic or anti-anxiety drugs?
I don't know the percentage. I would say most come in. Probably most leave on some kind of medication, but maybe not be starting with it. But But we certainly also see people that with therapy is enough and medication isn't needed. But therapy and medication is proven to be very effective, and is the way it often works out. Yeah. We have great psychiatric team supported by a great team of nurses, and yeah.
Could you speak a little bit more about the various forms of addiction that people present and how the therapists deal with addiction issues?
Our addictions program is a big one. We have teams that focus specifically on youth, and that's a group model and includes, we also has a group component that includes parents as well. And so they meet several nights a week. In our adult programs, we have several layers. We have intensive where they come in, I'm going to say at least 3 evenings a week. We do a lot of random drug testing as part of that. And the types of addiction vary all the way from gambling to opioids and alcohol, kind of the full gamut. For opioids now, we do have something called medication-assisted treatment, and Suboxone is a terrific drug which helps to lessen craving. And without the craving, it's way easier to stay in treatment and to stay clean. And so that's been very effective. And so we have some good physicians who have a real heart for this, who work hard to be flexible. Because when you have someone who's been addicted but says, okay, I'm willing to do this now, then you do it now. You never waste your opportunity. And so we do a lot of MAT, medication-assisted treatment.
Beyond Elkhart and St. Joe counties, are you serving a wider circle?
Yes, that was a real adjustment. So I mentioned in 2010, we took over and moved into St. Joe County. So the story there was Madison Center had been one of then it was 25 or 26 community mental health centers. And in fact, they had been the largest CMHC in the state. But they got into financial problems, built too many beautiful buildings at a wrong time. And they brought in a string of consultants who tried to right the ship, and it wasn't going well. It wasn't getting any better. There was some talk about fraud. I don't know if that was ever legit or not. But at any rate, at one point, they called us, the state called us, because they were really concerned about what was happening here, because they were big and serving lots of people. So they said, do you want to take over this operation? And oh, by the way, you need to decide soon because things are going badly. So we had about 6 weeks to make this decision. And so we had extra board meetings, and we looked over their books and thought, oh, goodness. But in the end, we decided we would do this. It was work we knew how to do. We knew that a certain percentage of the staff would likely come along. And, we knew the billing and, we knew the routine. So we did that. And so at 5:01 p.m. on September 24th, the state was that specific. We became the CMHC for St. Joseph County. And at that moment, their 7,000 clients became our clients. And we had about 225 of their staff that came over. We didn't interview or anything. We were just like, God bless you, come. I was a little fussier with the leaders. I kind of picked and choose on that, but for staff, I was grateful. And at that moment, then we really shifted from thinking just about Elkhart County to now thinking more regionally. And that's, so I've said a couple of things. That is a way to grow. And it's what I never want to do again. That was really an intense experience, but it was good. The other thing I would say about it, it's been interesting because even though these counties are right next to each other, and you know that we all go to South Bend, we go out to dinner, we go shopping there, but there is a line between Elkhart and St. Joseph counties. And so just getting to know people and players over there, it's coming, but it takes a while. you know, before that, I could walk into, you know, any gathering and I'd know somebody, you know, kind of thing. And over there, it's like, I don't know you. So we made many friends in the last decade.
Lori, I can't resist another historical note. In 1952, Thorazine came out, and that was for schizophrenia. And as you know, mental hospitals were full of schizophrenic people all around the United States. And several years after 1952, there was a dramatic reduction in state hospital patients throughout the United States because it allowed them to take their auditory hallucinations would go away, their delusions would pass away. And that was just an incredible change. But then over the years, the question was, when you have outpatient services, does money follow the patient? Right?
Yeah, not enough, right? Mhm. Yeah, we still have state hospitals in Indiana. They're all smaller and they do serve a purpose, but it used to be that folks in the state hospital would stay a long time. They don't anymore. Um, and so once in a while, there's talk about we should shut down some of these state hospitals. They aren't as full as they used to be, but they also tend to be big employers in small Indiana towns, and you cannot shut down a state hospital.
Well, we read in the Bible that we ought to love our neighbor as we love ourselves. I think we've learned from this Oaklawn story that love is pretty complicated, that love can involve dealing with government, dealing with professional psychiatry, dealing with philanthropy, dealing with accrediting agencies, working with employers, employees. Thank you for helping us see some of the dimensions of what you live with day by day, and we appreciate your being with us.
Thank you for the opportunity to talk about Oaklawn. And I knew this would be a friendly group that would get it, so that made it easy. Have a good after day.